Alice Hyde was down 13 million in 2022. Champlain Valley Physicians was down $54 million over the last 22 being a particularly bad performance. More over there. What's UVM's plan of how to manage those costs? And I don't know, maybe you could just respond. Is that those people need care just like they're people just like Vermonters, of course. But should it be Vermont ratepayers that are footing that bill?
To be clear, Vermont ratepayers are not footing that bill. So in our budget submissions, I think we've clearly laid out that the rate increases, both for Medicare and Medicaid and commercial, are driven purely by the cost inflation at Porter, UVM Medical Center, and CVMC. So that is the direct connection to the Vermont payers. The same avenues that we have here in Vermont are in place in New York. That's not the same regulatory body, but we deal with the New York payers there for the needs of the New York hospitals. We work with the state government there. Obviously, it's more difficult in New York than it is in Vermont because it's a much larger state, and the North Country is a very small portion of the overall state. But to be clear, the Vermont ratepayers do not subsidize New York care.
So I may be a little confused, and I don't have the numbers in front of me, but I thought I had seen transfers over to New York. You're telling me that there's no net loss to the network in terms of supporting those hospitals.
There's a net loss when you look at the overall performance of the network, and we have provided the Green Mountain Care Board over the years the net funds flows, both the revenues that come into Vermont, the provider tax revenue that's generated by New York patients coming to Vermont, the charges that we charge New York hospitals for their share of shared services. But yes, that is correct.
And maybe just one more on the same line, and the having those entities in your operating group, obligated group, well, does that have a negative impact on your bond rating?
Certainly. You see the financial results and the struggles there in New York are quite great. The hospitals, particularly in the North Country of New York, are all struggling. So we're working hard to improve performance. Some of the service conversations, obviously, you may have followed. We've had to have those difficult conversations and made those difficult decisions. So we had to close OB services in Malone as a way to consolidate services and try to improve financial performance. And so we're focused on improving that performance, but they do, as you see in our financial results, they do have a negative impact on the overall UVM Health Network finances.
I think my last question for today is sort of in follow-up to Member Lunge's, maybe it was Member Holmes's question about the sale of investments. Actually, the combination in your audit financials, you show or your profit and loss statement, I think you show what was budgeted as a $16 or $17 million sale of investments, and you're projecting a 61 for 23, $61 million income. And additionally, you also show, you were budgeted for a 10.7 NPR, and you're showing a 15.5 projected. So two places where, at least on that page, it looks like 23's turn is looking good for you. How do you can you reconcile those numbers for me with the story you're telling about how tough 23 has been?
Yeah, so when you look at that revenue piece and looking at our total margin, those are all market returns. And as we've all seen, the market has done well this year. That is realized income. That doesn't mean that we actually have sold investments. It means that the value of those investments have gone up. Some of them have been sold and has generated some realized income, but that's what you see there. 90 to 95% of that income that you see in that number is all market returns.
Is all unrealized because you haven't sold it.
Correct.
Is that what you're saying?
It's a piece of both. Some of it is realized and some of it is unrealized.
And it would be a strategic decision for UVM as to whether to realize those unrealized. It's a funny sentence, but you could sell them, right?
You could absolutely. And when but we don't. We had to last year and even some a little bit earlier this year. That's where you see for any of the unrestricted both cash and investments that we have, that's what has contributed to the days cash and on hand decline that you've seen. So we did have to sell some investments just to fund routine operations because the routine operations were not generating enough cash to pay the bills. So you don't want to be selling investments. You want to keep them in the market so that you can use them at a later date for capital projects, for unexpected events. So you never want to be in a position of having to sell your investments because it means you're not generating enough revenue in your core operation to fund all the expenses that you have.
So, and the other half of my question, I know I asked both about the sale of investments and the NPR numbers. Did you have a comment about the projected 15.5% when you had a budgeted 10.7?
So you were looking at the total margin?
The net patient revenue line. Yeah.
Oh, okay. The net patient revenue line, 15% versus a budget of 10 is what you're, okay. Yeah, that is as we've shared, I think throughout the day, a big piece of that is all our access improvement efforts. So we've worked through a significant amount of backlog in OR cases. We've improved our wait times for radiology. We've improved our wait times for clinic appointments. So this is, again, the balance. We're trying to meet all the access needs, and that certainly has generated more NPR than what we budgeted.
Okay, thank you. Sam, why don't you go ahead?
Thank you. Can folks hear me okay? Great. So thank you for the opportunity. And if any of as Mike said, if any of these questions move into territory that'd be better addressed in the executive session, please let me know. Just looking through the last 4 or 5 years of your audited financials, I'm wondering if you could describe a little bit in more detail some of the purposes of the subsidiaries that exist underneath the parent, particularly UVM Health Ventures and the Medical Center Foundation. Just wondering if you could describe what the purpose of those entities are.
So the UVM Health Ventures Corporation there are times when we make investments in private equity companies. So part of our investment strategy to be well diversified is we invest in publicly traded investments, bonds, and privately held companies. And for some of those investments, due to tax reasons, we do run some of those investments through the Vermont Health Ventures. Very, very small amount of investments that we ultimately have to run through there. And in terms of the foundation, sorry, that kind of predates me, so I might need to call on one of my colleagues here to explain what the purpose of that. Steve,
So the foundation is basically our arm for philanthropy. So we have the UVM Medical Center Foundation, that's philanthropy. It's a separate board that raises money for the medical center.
Thank you.
It does.
Are you-
It does.
Oh, go ahead.
It does not. Just to be clear, it does not have a balance sheet of its own. There are no assets that sit there.
Thank you. I appreciate that. Are you able to quantify the amount? You said it was small, Mr. Vincent. The amount held in, because I believe the network is an equity holder in the health ventures. Are you able to quantify that amount?
I am. We'll follow up with you on the exact amount.
Okay. Shifting over a little bit, following up on some of the board questions on the Population Health Services Organization. I'm wondering, and it's possible you mentioned this and I had missed it, how you plan to evaluate progress towards the, the outcomes and cost reductions that it seems to be is a primary purpose of the organization. How will you evaluate that over time?
I'll turn
Do you want me to go ahead, Rick?
Yeah, please do.
Yeah, so approach to evaluation for the PHSO is really in terms of initially implementation metrics, so things like hiring, care managers, assessments, care plans, then moving into process-based metrics, so looking at utilization year over year for population. So ED utilization, for example, or inpatient utilization, admits per thousand, sort of those types of, and then moving into outcomes over time. And so those outcomes will be cost-driven metrics and they'll be benchmarked, of course. And we'll use literature to drive some of that, and also our partnership with health services researchers, which is one of the things that we're looking to build in the PHSO, to have robust evaluations for all of the programs that we build across the PHSO.
Thanks, I appreciate that. Do you have a time horizon, short-term, long-term goals for when some of these metrics, we can expect to see or hope to see improvement?
So typically, if you want to talk about a particular program, and we want to talk about the care management program, which is, I would say, the one that is really most mature at this point, although still really growing. Typically, when literature tells us that you need 18 to 24 months of longitudinal care management before you see change and true outcomes. However, you can see short-term gains pretty quickly. And so some of that we are realizing and seeing now. A lot of the reporting we're actually starting to think through. So I would say that it's reasonable to think that within the next year, we will have initial reporting to be able to provide from the PHSO, and then that will obviously grow over time.
Thank you. I appreciate that. Shifting gears a little bit, a couple of years ago, the CEO of the Mayo Clinic made a controversial comment that they, at the Mayo Clinic, plan to prioritize commercial patients over patients that have public insurance, and then walked it back. And we've heard a lot of discussion today about the cost shift and the impact on commercial ratepayers and the importance of commercial revenue. I'm wondering if UVM Health Network or any of the entities within it, is there any prioritization for non-emergency inpatient or outpatient services for appointments for patients? Do you prioritize commercial patients in any way?
Absolutely not. And I think we have some physicians here on the screen that can also add in from a provider perspective, from a clinician's perspective. We're insurance blind. We take care of everybody that comes to our door, and we essentially, obviously, there are front end things that we have to do in terms of prior authorizations and other things to get patients financially cleared, but we don't restrict access to care based on insurance in any way. Steve, I don't know if you want to add anything.
Couldn't have said it better, Rick. We absolutely are payer blind to all the care we deliver.
Okay, thank you. Last question, focus on race equity, particularly, as I know that's been an area of investment in, particularly in your DEI department. I'm wondering what metrics you've specifically identified to hopefully make progress on in the coming years, and how you plan to evaluate progress in that.
So for that, I'll turn to you're probably wondering which one I'm going to turn to. So I'll start with Sunny first.
Sure. So it's a great question. We have a number of metrics that we're looking at, but I'll just start with the really basics around education. So we have this year come up with a unified education plan for our entire organization. So all 15,000 plus employees, plus our board members, with a goal of getting 80% of our staff educated on just simply the basics of what it means to be diverse, how to have those conversations with each other so that people feel safe and can bring the sense of belonging to the organization. And then for all 100% of all new employees going through that training. The second is, how do we actually increase diversity in every way that we look at it across our organization? So whether that's race or ethnicity and non-English speakers or sexual orientation, gender identity, ability, poverty, how do we bring a more diverse group of people into our organization? What we realized is that our metrics today are not great in the way that we've captured them. By that, I mean, probably somewhere between 10 and 15% of all of our staff, if we look across all of our institutions, have left that question blank around race and ethnicity as a simple one. But it's even higher. That is, that they left it blank if we ask about sexual orientation, gender identity. And so before we can identify growth in those areas, we need to start by making sure that we have an adequate capture of the data. So starting in September, we're starting a new campaign across all of our entities just to simply create safety so that people can adequately and safely feel like they can report on their own identities. And so that's the two big pieces across the network. And then when we look about healthcare equity, that is the quality of care that we deliver across our network equitable? We know it's not today, meaning in the metrics that we're looking at, so we're looking at a number of them, and David probably has a much bigger idea of this, but I'll give you the ones that I'm focusing on. Breast cancer screening, colon cancer screening, diabetes treatment, so hemoglobin A1C as a measure of diabetes, and hypertensive treatment. We know that if you're Black, if you live in a poor area, every one of those measures is lower than if you're white or live in a zip code that has a higher level of wealth. And so we've started in this year, FY23, to go forward on trying to identify what do we need to do to improve those and focusing on those particular metrics to try to move forward. So it just gives you an idea. There's a lot of work going on and a lot of work on across our organization, just to bring those to light and to show the particular areas. So if you're practicing in a particular zip code, we want you to know what your numbers are and what you need to do. So that's the work that's going on this year. It ties into the work that Jessica was mentioning around our population health services work, that we need to go out and really drive this out, not just keep it inside, but first starts with just being able to make sure that we have adequate data on that. So thanks for asking.
Thank you. Appreciate it. Back to you, Chair Foster.
Thanks. One quick follow-up on the health ventures. Is there any University of Vermont Medical Center or Health Network money that goes in to fund the investments that makes?
Yes.
Okay. And are there policies prohibiting health ventures from investing in companies that UVM Health Network executives have a stake in?
I'll look to Eric. I don't know if you're able to answer that.
There are no investments by UVM Health Network Ventures that are in companies that, to my knowledge, Chair Foster, are owned by UVM Health Network executives. Part of the reason of having health ventures is to support research that may be commercializable by our physicians who are also employed by the university. And so in that sense, there may be investments in, for instance, a new invention that's being worked on and partially owned by a professor physician, but not on behalf of leaders at the UVM Health Network.
Yeah, what I'm getting at is just making sure there's policies where the money that's being funded into Health Network, from Health Network, isn't being used to invest in products that executives have, obviously.
No,
I mean, you get that, Mr. Miller,
yeah,
I'm sure.
no, it's not the case. And as you know, as a 501c3 organization, we also have very, very strict conflict of interest policies and controls in place that prohibit us from engaging in interested party transactions. And of course, we abide by those scrupulously.
Of course, right. I'm going to just draw your attention to a video interview with Z-Dog MD and Marty, I forget his last name, but it interviewed Chris Jones from Health Ventures. It's from January 15th, 2020. And there is some discussion of the JP Morgan conference and what hotel rooms cost and how much it costs to get a cup of coffee and things like that. That segment's in the first early 5 minutes or so. And I just wanted to flag it. I don't know what they were really saying, but it sounded expensive. And I just want to make sure that kind of expense, they didn't say they were spending that money, but it's worth looking at. Please take a look at it. And, we don't want to have that kind of expensive hotel rooms and the like. And I don't know if that was actually going on in that video or not. It wasn't really clear. I will turn it back to you folks for any closing statement if you have any, and then there's some hands raised and we'll turn to that after. And thank you.
Chair, I think we've been doing the public comment before the closing statements. So I think that would be the appropriate order.
Great. Yeah, great.
Yeah.
Thank you. Yeah, even better. And Ms. Brown, thank you for waiting. Your hand was up first.
Hi, can you hear me?
Yes, we can.
Okay, thank you. My name is Betsy Brown. I am a lead at the UVMHN Provider Access Services Call Center. Thank you for this opportunity to speak. And before I start my comment, I'd like to say that I've been on this Zoom since 8 o'clock this morning. I have been patiently waiting for hours, listening to all of you. And I presume that all of those other people from the public who are here to speak today will get the opportunity to say what they have to say. I have worked at the PASS call center for more than 14 years. I am a member of the UVMHN Support Staff United, the newest and biggest union at UVMHN. There are over 2,300 of us in over 140 different titles. It is a diverse group at the bottom of the pay scale at UVMHN. We are the backbone of the hospital. We clean the rooms, cook and serve the food, draw patients' blood, help take images, help dispense medications, register patients, transport patients, bill patients, distribute supplies and equipment, schedule appointments, answer phones, page providers and staff, call the codes, care for patients, many of whom are challenging and sometimes violent. I could go on and on. Without us, the hospital simply cannot operate. Providers, managers, directors, vice presidents, and those at the very top are paid anywhere from 3 to 32 times more than the vast majority of our union members, comparing $31,000 for a full-time union member versus over $1 million for someone at the top of the hospital. We all pay the same premium for health insurance, regardless of our pay scale. The members of UVMHN Support Staff United should be paid a livable wage, and health insurance premiums should be on a sliding scale based on a pay scale. If UVMHN is allowed to increase their fees, they should be directed to first use their money to support their most important resource, the staff who work for and with them. Why build new facilities when they are unable to hire and retain staff to operate the facilities they already have? If the staff is respected, paid a livable wage, and have fair access to health care themselves, the hospital will be able to retain staff and serve the community safely. Thank you.
Thank you for your comment and your patience, Ms. Brown, and we will take every public comment for as long as we need to. I appreciate everyone waiting. Let me see who's next. Ms. Gutwin, please go ahead.
So I just muted and turn yours up.
Okay. Thanks. I'm Sharon Gutwin. I'm the owner of a physical therapy practice called the Rehab Gym. I'm also a member of the Green Mountain Care Board Advisory Committee. I appreciate UVM Health Network. I have gone there for care and will always be grateful. My comments are not as much for the direct hospital care, but more of care that can be delivered in other non-hospital based locations, more in communities. I think UVM Health Network provided a formidable presentation, but what I felt is lacking is any awareness or appreciation that they're not the only business in the Vermont healthcare system. They're a large part, the largest part, but the best system requires collaboration, not autocracy. And I feel that the sense of autocracy or being in a bubble, and I understand, I mean, everybody representing UVM Health Network is here to only advocate for UVM Health Network. I understand that. But it shouldn't operate in the bubble. And if it operates in the bubble, that's the core of what I think is negative, that stimulates the growth, that is becoming more of a monopoly instead of a collaboration with the other healthcare providers within this Vermont healthcare system. And it's a small state. We all know each other. We should be able to work in collaboration and cooperation and not be adversaries. The reduction actually in healthcare expense is less about being more efficient or reducing the delivery of care, but reduction of healthcare in general. We need less hospital care because that is the most expensive care. Of course, it's most expensive for all the reasons laid out. But we can avoid having as many Vermonters going into this expensive care that is driving up the insurance premiums. So as long as focus is on financing a hospital-centric healthcare model, healthcare expenses can only be expected to rise, and at a higher rate than the community-centric care model. And I trust that everyone that is in this discussion, over 100, are listening to this, that we really, 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 really all want to be healthy Vermonters having a happy life. That's fundamentally why we're all here. I want that. I believe people in the hospital want that. I don't compare my business, the Rehab Gym, to a hospital because it's not apples to apples. But I can compare my business to the outpatient PT model that is owned by the hospital. And I can speak about that, and I want it to be on public record. We face the identical inflation rates, hiring challenges, the need to upgrade, the repair, the pay of bills. I even have an elevator in one of my locations. I just spent $9,000 to repair that and listened to a whole lot of complaints while it was under repairs. Our payer mix is identical. We are also payer blind, and we have uncomped care. Our budget shows actually a higher revenue percentage going to employee comp than 60%. The major difference is, as Owen alluded to, are that the reimbursements are up to 4 times higher for same services in a hospital-based outpatient clinic. And we know this because of the CMS transparency ruling that both hospitals and commercial payers are now obligated to contribute to. So it's not yet user-friendly, but my daughter, who is not needing computers to be user-friendly, has dived in. So all of this, all of the CPT codes that we are under can be compared apples to apples. So when I say it's 4 times higher, there's evidence of that, and I provided it to the Greenmount Care Board. The rules are known. Like what did confuse me was it sounded like people that were representing the hospital didn't really know what the rest of the healthcare system was facing. So that's kind of why I'm speaking. I'd rather not. I'd rather be outside enjoying my day. But I think that also speaks to the point that has already been mentioned, that it's not positive. It doesn't shine a positive light on the hospital. So we'll pretend it's not there and maybe it'll blow over. Well, my business has reached the critical point where the lead balloon has gotten heavier and it's falling. So after being at near flat rates for since 2015, we're at the breaking point. And what reality presents us is after reducing our CEO, CFO, and owner and is as low as we can go. I'm on $24,000 a year. I can't find any more money to squeeze. So this is where we're at. If we cannot get rates from the commercial payers, which have already testified, Tom Weigel from Blue Cross and Blue Shield said that that because the hospital demands what the Green Mountain Care Board provides, they have had no choice but to have that come from everyone else. And I'm speaking for probably every other non-hospital based business and possibly even hospitals in Vermont that compete with you. I don't know, but I do know this, I'm not alone. And I am having to make a very painful decision after 20 years in business and the major provider of physical therapy in the state of Vermont, who is at the forefront of reform in preventative care, trying to keep people out of physical therapy, out of hospitals, out of doctors' offices, and can provide plenty of evidence that that's effective in this medically oriented gym. I have no choice but to go out of network and get the higher out of network rates. This goes against my very reason for going into business. And if I go out of network, there is a potential for the cost shifting to be even more extreme. Speaking of cost shifting, I've heard nobody speak of the actual cost shifting of the private community-based business towards the hospital to meet demands. The money has to come from somewhere. It's not the trees. And so if there's a limited amount of commercial money, we are not getting it if the hospital gets it. Couple more things. The margin and volume, they do matter. Costco shows how low margins and high volume do cover the bills. And the rehab gym has had the pleasure, being the size it is, to be actually strong because we have high volume. So the pennies we make on the dollar can go farther. And then last thing is hospitals and other healthcare systems. Oh, I'm keeping the finger in my role as an advisor to the not an advisory committee to the Green Mountain Care Board. I'm keeping my finger on the pulse of what is going on in the nation. Certainly what Vermont is facing is really not unique. It's nationwide. And there are systems and hospitals that are reducing the administrative roles along with salaries. Out of the fact that they're forced to because they don't get all the money they want, but others strictly because they're being proactive. They see it's not sustainable. When I heard the term, what was it, dartboard number, 24%, I was in my living room, that came on the news and my jaw dropped. I mean, everyone in this call and on the Zoom should like stop and think, 24%? What? So I want us to stop thinking of individual bubbles. And I'm 66. I'm not going to be in this profession that much longer. I would love to see, before I leave this profession, an actual paradigm shift where we're starting to focus on where we can actually reform healthcare. It's not from a hospital. You can't put the fox in charge of the hen house. It's like Kentucky Fried Chicken working on people to stop eating chicken. Prevention, health, wellness, fitness, mental, physical, is best applied in communities in a variety of settings as universal as individual mankind presents. So I am hoping, although it's a big ask, that the hospital can actually start focusing on what it does best, where everybody agrees the hospital needs to take care of the sick and injured and do a fabulous job. And you should get paid for what you're doing to save people's lives and create health when people are sick. Let other providers that have absolutely nothing to gain from a sick person and only everything to gain from a healthy person that's basically plugged back into an active life. That's physical therapy. That's social work. That's primary care. That's occupational therapy, pediatrics, that's speech therapy. There's those professionals, along with the fitness industry, health coaching. If we pay anywhere close to 24%, even over the 8.6 that the board has originally tried to stick with, that is money not being spent on the healthcare, true healthcare of Vermonters. And it's investing in a sick care system that can go so long before it implodes. Thank you.
Thank you, Ms. Gutwind. Mr. Hoffman?
Hi, can you hear me?
We can, yes.
Chair Foster, if it's okay with you, I have a technologically challenged guest who I'm helping. Would you allow him to go, and then I'll follow him here on Teams? If you unmute line 917-696-7902, I have David Taft from Milton to share, and then I'll follow his call on Teams.
Absolutely, that's no problem. Ms. Lajeunesse, do you know how to unmute Mr. Taft on that number? Not sure I do.
Microsoft Teams does not allow us to unmute individuals. I'm sorry.
Okay, so you need me to unmute our phones?
star 69, I believe.
Hello.
Hey, Mr. Taft, it's Owen Foster from the Care Board. Can
Okay.
hear you fine. How you doing?
Okay, I'm doing fine.
The floor is yours if you'd like to make a public comment for us.
Oh, okay. Unfortunately, my aspect that I'm concerned about is this all started for me back in 2019. I ended up with a medical situation where I was brought to the emergency room, and they did some blood work on me. And unfortunately, my PSA level for prostate cancer was elevated in the emergency room. My doctor, who I'm sorry, but I can't remember his name at the time, was, I don't know if he was notified of it at the time when I got it done, but unfortunately, that, like I said, it was in 2019. I ended up with a new doctor in 2022 who did some blood work on me, and she diagnosed me with prostate cancer, and I was given over to a cancer doctor, Lester Cole, who determined that I did have the prostate cancer. And when I asked him how long I've had it, he said that apparently, from what he could see in my paperwork, I was showing numbers back in 2019. Unfortunately, I didn't show any signs illness-wise to tell me something was wrong, but it just, unfortunately, from 2019 to 2022, I went all that time without knowing, because no one took the initiation from the emergency room area to either notify my doctor, or my doctor didn't notify me. So I went 2 years with the cancer, which could have probably been taken care of by surgery if it was caught in time. And unfortunately, by the time they noticed it, it already spread. So the surgery was not an option for me. So I ended up having to go through numerous radiation treatments. And it just, my biggest concern is what I went through, what I could have, I mean, right now I'm doing fine, but the aspect of the whole thing is, why wasn't my situation with cancer, which is more of a priority of anything, brought up to the point where someone should have notified me right off the bat? I know back then they had the ordeal with the COVID, and I feel like even though, you know, they were trying to do their best, my cancer situation got put on the back shelf. And by the time I was realized what's going on, it was too far, and my procedures were more extreme than they should have been.
And me and my wife had been through a very emotional time because of it. And I've been having problems with health insurance to the point where one time I got it, one time I don't, because I didn't have Medicare at the time. And I had Medicaid, but they've been bouncing me back and forth on I have it, I don't have it. But the issue of it all is how much money was spent out of my pocket and the hospitals on a procedure that could have been taken care of a lot sooner. And like I said, me and my wife went through this financially and emotionally, where unfortunately, I hate to say it this way, but I feel myself that on my behalf, the hospital dropped the ball in notifying me to let me know. And now I gotta fall down on the brunt of it and make the best of what I got.
Mr. Taft,
Yeah.
wasn't sure if you were finished, and I didn't want to interrupt if you have more that you'd like to share about your experience.
It just it was very frustrating, and I just feel like I think the hospital could have been able to step up a little bit more on their prioritization, whether it's the emergency room or whatever, with their communications with each doctor and each patient for the seriousness of their illness. If I only had an infection in my throat, okay, yeah, no problem. That can sit back a little bit if need be. But I think anytime somebody comes down with any form of cancer, whether it's a minimal type of cancer or a major, I think that should be a priority one into someone's health to get taken care of more immediately and not thrown onto the back shelf like mine did until a new doctor decided to do blood work, and that's how they found it. So I went 2 years on the back shelf with cancer, not even knowing I had it. Were prioritized, I should have known about it right off the bat. And I just feel myself that somewhere's in the hospital, someone dropped the ball.
Has anyone reached out to you about financial assistance issues the last few weeks?
They did, but they were telling me that because of supposedly financial situations, the Medicaid that I did have, they took from me. They said I didn't qualify for it. And yes, I'm on Medicare right now, but even though it only covers so much, with me being on disability now because of my COPD that happened in 2019, I'm on a fixed budget. My wife has insurance, but she can only afford insurance for herself and not for the two of us because it's too expensive. And even with the insurance that I have, I'm taking more money out of my pocket to take care of the medications I need. And even though I got my insurance, it's still not enough to balance out for me financially. I'm still struggling trying to get my medications because my insurance won't kick in until I meet this requirement every month. And by the time I do, it starts all over again. because it goes monthly. So in all long run, all my medication's coming out of my pocket. So it's like I'm paying all this money for health insurance. I'm paying out money for my medications. And it's like, why am I spending all this money for on insurance and things if my insurance ain't going to cover anything? And it's gotten to the point where I'm almost to the point of, okay, if I get sick, can I go to the hospital? I really don't know, because that's money that I can't really afford to pay. My medication, can I afford that? Well, if I'm in good needs with a good ward upstairs, hey, I might be able to get by without taking it. But do I have that choice? It's pretty sad when you have to take and balance your health over a money situation. And it's just, that's the part I'm getting at, where, like the other woman was saying, you guys want to raise your system by 24%. I'm on a fixed budget. I cannot afford to have my insurance, my medication and everything go up just to help satisfy you guys. And I think I speak on behalf of a lot of us who are on fixed incomes. It's going to get to the point where, unfortunately, we're going to have to start making a decision on our medication, and also being able to go in and get ourselves taken care of through our doctors, because it's getting to that point where we can't afford to do it no more. And where do we draw the line? Enough is enough.
Chair Foster, this is Dr. Leffler. If I can get Mr. Taft's name and phone number, I can have patient advocacy call him first thing tomorrow to see if we can help.
Okay. I have talked to the hospital. They put me on a payment plan. It's like, okay. I received 2 bills from a collection agency because the hospital sent 2 of my bills to the collection agency because supposedly I was taking too long to pay on my medical bill. I can only give you guys so much money. And if it's taken so long that you guys have to put me in a collection agency and ruin my credibility, I mean, I'm sorry. I mean, I called you guys, we made plans to do a payment plan, and then you pull this on me. It's like, I might as well talk to a wall. You guys are going to do what you want, and you don't care about us. You just want your money. And that's how I feel. I'm sorry.
Mr. Taft, I'll get Dr. Leffler's number to provide you, or somebody that he can, in case you want to reach out again. Maybe it'll help. And I acknowledge what you've been through is excruciating. You can keep speaking. Yeah.
Okay. David, did you have anything more to share?
I'm pretty much set on what I need to say. I think I got my point across that, I can only do so much and I can't do any more. And there's people out there like me who are in that same boat. And all we're doing is asking for a little bit of consideration and a little bit of help from the hospital to make things easier on us. That's all we are asking. And, I just have to sit back now after saying what I had to say and see what happens. and to do the best I can. And hopefully I don't have to file a bankruptcy situation because of paying all my medical bills. And also taking the chance and having to jeopardize my health because of my medication and getting the help that I need. So that's where I'm at right now.
Mr. Taft, thanks for taking the time to participate and share your experience, because I think it's really important for all of us to, it's sobering and it's important. So thank you for speaking up and participating and being here. Mr. Hoffman, did you have a comment as well, or?
Yeah, I have some comments I'd like to make, if that's okay.
Of course.
Thank you. I want to point out that Mr. Taft's trying to diligently pay down this debt that really isn't his to owe as a result of a misdiagnosis. And with all the investments in health information technology and care management and population health and on, this should have been caught. And so my hope is that instead of destroying his credit and possibly causing him to go bankrupt, this hospital can help him not only retire the arrears, but provide him the care he needs free of cost going forward. But I want to make some other comments. The type of diagnosis and treatment David needed in 2019 it's the fundamentals of medicine, and that requires sufficient staffing. Since 2018, the network has coordinated the redirection of hundreds of millions of dollars that would have otherwise been available to direct patient care to the sexier work of population health, IT execs paid at 15 times the median income of Vermonters who fund their salaries, IT projects at 3 times the national average cost, some of the most costly per square foot vanity building projects in the country, and concurrent to expanding its revenue and balance sheet, Dr. Eapen's predecessor went on a more than decade-long spending spree and acquisition endeavor. Hospitals presently reminds me of the state of retail before I left it for healthcare. Massive consolidation transpired from the late 90s through the great financial recession. Enormous sums were spent on expensive but low margin acquisitions and handsome executive salaries to manage them. And then the business model broke after the great financial recession, when tremendous deflationary pressures, particularly with the entrance of online retailing. Shareholders raced to justify every line item of expense, returning conglomerates to the fundamentals. And eventually, those conglomerates either went bankrupt or were chopped up into what was valuable. Similarly, hospitals post-COVID faced tremendous inflationary pressures, which have broken their business model. Their model's now broken, and they have to respond. Vermonters are the health network's shareholders, and the Green Mountain Care Board is those Vermonters' board of directors. As with retail after GFR, the Green Mountain Care Board in the state of Vermont must examine every line of cost, examining its return on investment. Chair Foster has repeatedly asked academics and hospital executives how to balance controlling costs and not reducing access to care, which is routinely held out as a threat if the budgets aren't granted. There are 4 main areas where nonprofit, and I say that in quotes, hospitals plow profits: executive compensation, vanity building projects, excessive IT spending, and unproven population level endeavors with poor outcomes. The 4 top executives seated before you today shared an aggregate of $4 million in C-suite compensation, averaging to $1 million per executive, or 33 times Vermonters' median income paying their salaries. Many more were on this call today. Dr. Eapen's predecessor went on an unbridled spending spree on executive recruitment, snatching up a former regulator at a cost of $800,000 annually, another former regulator from Vermont AHS, presumably at 15 times median Vermont wages, a former U.S. attorney who's on this call today at $610,000 or 20 times Vermont median wages, a former Blue Cross Blue Shield Vermont executive on this call today, again, presumably at 15 times median wages, and the list goes on and on. There are members of this Green Mountain Care Board regulating these very executives equally qualified to perform some of their roles, and yet you work for many, many multiples less, as does the governor of the state of Vermont. The health network, even accounting for their proposed change in math, which would have reduced their admin to clinical comp ratio from 2.1, still remains at the high whisker mark, or more than 71% above the national median, demonstrating, as Member Walsh said, economies of scale have not been realized. And I will enumerate further momentarily how this is a top-heavy organization. Reducing the network from 24% to the median of 14% in this category would yield some of the savings necessary for the hundreds of frontline staff who have written into all of you this week, crying out for help. It's the type of move shareholders would demand after leadership abandoned management fundamentals for a decade. The health network proposes an outpatient surgical center that on a cost per square foot basis is the most expensive proposed build in the nation at 3 to 5 times the cost of similar builds. No less than 2 hospitals and a nurses union have petitioned for interested party status to protest the ill-conceived nature of this proposed $150 million investment to be made by Vermont tax and premium payers. Such profligate spending results in facility fees and outside consumption of scarce healthcare dollars in this system. This is exactly what Ms. Gutwin was talking about, which every year risks to put folks like her who offer higher value, lower cost community care out of business forever, exacerbating the current well-documented access to care crisis Vermont faces. And while the network may claim it's necessary to do these things to recruit top talent, go down to Rutland and ask the state of Vermont's highest paid physician, Mel Boynton, if he stayed at Rutland Regional Medical Center all these years because of its lavish atrium. The health network has spent hundreds of millions on IT infrastructure since 2019, but has never told Vermonters what ROI they've received for it. In 2024 alone, the network proposes to spend $150 million on IT. That's 3 times the national average of 3% of operating expense for similar hospitals. On this line alone, $100 million in 2024 exceeds the national average spend for the same. Top-heavy management for this division includes an SVP of network IT at $655,000 annually, or 20 times Vermont median income, a network VP of Health Informatics at $450,000 or 15 times Vermont median income, a Chief Medical Informatics, again $450,000 and 15 times median income, a VP of Enterprise Info Management and Analytics, presumably at similar comp. The network has led the state's health reform efforts. Since 2018, hundreds of millions of scarce healthcare dollars have been poured into their ACO. And now the network proposes to spend another $23 million this year alone on a duplicative population health services organization, and only provides very high-level aspirational language around its aims and accomplishments over the past 21 months. This is eerily reminiscent of the same language its ACO used for years before former AHS Commissioner Mike Smith said it needed to move on from being aspirational to being operationalized. Top-heavy management in this sector includes $2 million spent on ACO executives, $590,000 on an SVP of high-value care, $510,000 on SVP and Chief Population Health and Quality, an Assistant General Counsel of Population Health, whatever that is. I've not seen that at other hospitals, but apparently it's necessary for Vermonters to pay for, as well as a VP of Managed Care Contracting who was on the call today. I cautioned their ACO in 2018 it could not achieve its aims with the analytics it possessed. They were not actionable or reliable, despite continuing to represent otherwise to this board, DEVA, the legislature, and the public otherwise. For that, I was terminated by my supervisor. That supervisor is now the VP over analytics I just mentioned a moment ago for the health network. 4 years later, Blue Cross Blue Shield Vermont would cite lack of actionable data and consequent interventions as part of its reason for withdrawing. And even the NORC report assesses that providers find the analytics similarly insufficient or irrelevant. Since 2018, the network's leadership of healthcare reform has seen its 3 most important clinical quality measures, hypertension, depression screening, and substance use disorder screening, underperform, as hypertension scores bounced between the 60th and 70th percentiles, and depression and substance use disorder weren't even benchmarked, and rates of uptake in screening showed little improvement in them. From 2018 to 2021, what CDC data tragically shows us is that hypertension, suicide, and substance use disorder related deaths grew far in excess of national average for age-adjusted mortality, and likely resulted in over 500 additional age-adjusted deaths beyond national averages over the same period. This isn't the high baseline that Vermont already has over the national average for those same measures. This is just the growth of growth from 2018 to 2021. 4,000 Vermonters died in excess of the national average at baseline, but just the growth of growth yielded 500 additional age-adjusted deaths. On these important quality measures that hundreds of millions were poured into, time to get back to the fundamentals of medicine. Every line item matters. The time for pie in sky is over. The public would make the following requests accordingly. First and foremost, immediately clear the credit history of David Taft after it was destroyed. Reimburse him for all he's paid to treat stage 4 cancer that metastasized because of a missed prostate cancer diagnosis in 2019. Immediately pay for him to receive a second opinion on his current treatment course, and reassure him that the prostate that wasn't surgically intervened, in addition to the cancer found in his ribs, will remain in remission with the health network's chosen course of treatment. Provide him free care for all remaining course of treatment. Deny the current certificate of need for the surgical outpatient center until and if its projected costs are brought in line with national cost per square foot averages. It can be shown that the UVM Health Network will provide the better quality and cost of care than current care in the region, or by those who, like the Green Mountain Surgical Center, have had their requests denied to expand specialties in the region while offering higher value, lower cost care. Reduce the 2024 budget by an amount equal to the excess of 3% of operating expense for their IT investments, currently $100 million. And demand an ROI accounting for all Epic investments made to date. Finally, we'd ask Dr. Eapen to perform a thorough accounting and evaluation of the executive leadership that has been rolled up into the stable over the last decade, including their total compensation as compared to national median averages for the same. Thank you.
Thank you. Normally comment on public comment because they're all really valuable, and so I don't get a chance to do that. And I don't think it's appropriate, but I will just thank you for pointing out the care board staff that is really talented and works really hard. And I think, they take state salaries and they do great work. So thank you for pointing that out. I appreciate that. And they've had a really hard couple weeks doing this work. So thanks. Ms. Snell, please go ahead.
Thank you. I did want to, first, I wasn't going to speak up at this meeting. I was just here to observe. And then there's a few comments made that I just felt like I needed to respond to. In particular, Mr. Miller's comments about executive compensation, because I found that very disturbing that that kind of numbers and that kind of information is being withheld. I do hope that in executive session, that when it is brought up, that the possibility that the Green Mountain Care Board could sign an NDA to get that information. We have had to do that in union negotiations in the past to get that information. I do hope that whatever hospitals the UVMC and network administration is using to benchmark themselves against is the same hospitals that they're using to benchmark and market their own employees. When we bargained back in 2018, they kind of had the audacity to compare us to a 100-bed rural hospital in Maine when they were looking at our salaries. So that has always stuck with me, that that's how they look at their employees, unfortunately. And I do want to thank Dr. Leffler for somewhat standing up for union negotiations and being an important part of our work at the Academic Medical Center, that we do bring value and we do bring employees there because they know that they have certain rights and rules that they may not have had at other hospitals. My other comment, and I think that Mr. Hoffman before me spoke much more eloquently than I will ever be able to, is on the network, the shared administrative services. I agree with him that the expenses, the $407 million, the shared total expenses is kind of outrageous. And especially in my mind, when I was looking at it, and granted, I'm looking at it in very broad terms, but when you look at the managers, there is one manager for every 6 employees average at that level. And that is a little mind-boggling to me that those employees would need that kind of oversight. And if they truly do, then something needs to change at that level. I will stop there. And I thank the Green Mountain Care Board for all of their work. And I thank the UVM Medical Center for being in the hot seat for these, 7-8 hours now. And I do appreciate everyone's time and attention on this very important matter.
Thank you, Ms. Snell. And I believe the Care Board scheduled a hearing with you and the nurses soon. So thanks for doing that.
Yes,
we
absolutely.
We didn't ask a lot of questions around the nursing shortage because I know we have that scheduled.
Yeah.
So Miss, I was gonna call on you. Sorry. Yeah, you got your hand went down. So Miss Cyril Schrader, go ahead.
Hi. Thank you for the time for me to speak today. My name is Becky Cyril Schrader, and I've worked for UVMMC for over 11 years. I first worked at what was originally, when I started, PPS, and then it became the Regional Transfer Center. I left there in July of 2020 when I was laid off along with 2 of my coworkers because the massive Epic project made our jobs absolutely obsolete. In January of 2021, I started at Provider Access, the call center. I actually overnight worked a 12-hour shift from 7 p.m. to 7 a.m. and have been on this Teams meeting off and on since 8 a.m. this morning. I've heard a lot of numbers, but what I want to talk about today, right now, is people, is human beings. Not only have I worked for the hospital for over 11 years, I've been a patient of this hospital for much longer than that. I am here today to implore the board to hold UVMMC accountable for the care given to its most valuable asset and resource, the human beings that make this hospital run. We are the invisible workers that until we formed our union were easy to ignore. We answer their phones, we clean their rooms, we draw labs for their patients and process them. We page out their codes, we cook their patients' meals, we fill their prescriptions, and so much more. No employee working at not only Vermont's largest employer, but also its largest healthcare provider should have to worry about homelessness, food insecurity, or the inability to afford health insurance, healthcare, or medication
due to being paid poverty wages. Right now, the taxpayers of Vermont are funding UVMMC, refusing to pay a livable wage in the form of food stamps, housing subsidies, and Medicaid and doctor, taking the taxpayers' money and robbing their hardworking employees of their dignity. My office recently started a food pantry in our break room because so many of our colleagues and coworkers are so food insecure, they were coming to work, working full shifts without eating because they were deciding between rent and healthcare and food. I would also like to point out that there are multiple executives in this hospital who make more in 1 week than I make in 1 year. Another way that UVMMC has chosen to save money is by not having 24-hour security in multiple sites that have 24-hour staff. At least 2 of these sites have been breached by people not associated with the hospital. When I asked about adding security, they locked the elevators instead and said, well, they can't move from floor to floor if we do that. I asked for a keypad. They said, we'll see what we can do. I demanded a keypad. Rather than buying a keypad, they went and found an empty office and stole it off of that door. We also received an email giving us tips on how to keep ourselves safe. It's my job to be safety and security for myself. I was there one of the nights that people broke into the building I was working in. I don't like feeling unsafe at work. That's not a way to save money. As a patient, the care that I have received from UVMMC over the years has been a mixed bag. I have received wonderful care. I have also received care that has been affected by worker retention rates that are terrible. Major medication errors caused by new staff. Major scheduling errors with surgeries and testing that nearly cost me going to my grandmother's funeral because nobody was communicating with each other and people didn't know what they were doing because they aren't being retained. If you don't pay people a livable wage, they won't stay. And you constantly have a lack of knowledgeable, skilled workers. I know that UVMMC can do better than what they're doing right now. They need to pay staff enough to get their loyalty and to get them to stay. I know of people that are looking at jobs in retail, in the food industry, because they're paying more at those places than they're paying people who help page out and run the codes that save patients' lives. That's not an okay way to run a healthcare industry. I stay at my job because I believe in the work that I do. I love helping patients. When I help a patient, it feels so good. But I also deal with a lot of frustrated and angry patients that aren't getting the care they need and deserve. And I try my best to help them. And I don't want to have to leave this hospital. I don't plan on leaving. I joined the union and I'm involved with the union because I think we can do better. But that starts with making sure that the hospital is paying the lowest paid workers in their facility enough to live on so that they can stay and they don't have to leave. Thank you very much for the time to speak today.
Thank you very much for your patience. I'll quickly apologize to all the public commenters who waited. I think I mismanaged this time a little bit. It's my first UVM hearing, so I'll try and figure it out a little bit better for next year, but thanks for sticking around.
Thank you for your work.
Thank you. Thank you for your work. Mr. Davis?
Thank you, Mr. Chairman. I've got 4 or 5 comments, but they're going to be really fast. I thought the discussion about what Vermonters can afford to pay for healthcare didn't really go anywhere. It might be of interest to you to know that in 2013, the then Green Mountain Care Board hired a consultant from Johns Hopkins to to ask that question directly. And what he came up with was the idea that that what Vermonters could afford to pay on a given year, more than what they paid the previous year, would be 3%. Now, I'm pretty sure it's not. I think they put in an extra 5% just because hospitals at that time were trying to go to single payer. But in any event, if you want to know what they can afford, then that's a really good way to find it out. And use something like the St. Louis Fed to figure out the data, like what is the actual gross state product. Anyway, number two, the whole discussion about market power, it strikes me as significantly unrealistic for this reason. There's no question that market power is rampaging across the whole United States and the entire healthcare industry, but not here. You cannot, UVM nor anyone else, including Blue Cross, nobody can charge the public or the payers any more money than the Green Mountain Care Board allows them to do. They have total control over the commercial ask. Third, the question of whether UVM is a financially valuable organization, a really financially efficient organization. You can talk all you want about how the Dartmouth Health Atlas just doesn't mean anything. Of course, the Dartmouth Health Atlas means a lot. Okay, but what I would suggest is, okay, put that aside for a minute. I understand that it's important to some of the members to lay down this marker so that they can get an answer that they want. But I would say this: if UVM is making too much money, okay, then that money is gonna really drop to days cash on hand. Okay, and if you look at 6 years of days cash on hand, you'll find that there were 18 data points. There's 3 rating agencies. 6 years, that's 18 data points, and 17 of those data points saw that UVM's financial situation, okay, was below any of the rating agencies' numbers that they would use to charge interest rates for anything that the company does. The fourth is one of the things that I've talked about here, and it hasn't gotten anywhere, but there's all kinds of data in the OneCare archives that never appear. One of them is the PQI readings, okay, that show that UVM, compared to all the other hospitals in Vermont, okay, is so far ahead of them in quality that it's really just sort of, in a way, embarrassing. There's another piece in there that does not involve UVM or Dartmouth, which is a potential avoidable utilization, which shows that of the non-network network, the 11 small hospitals, that 20 to more than 30% of their admissions out of their ER are not justified. None of that surprises me. It's very clear the case that the board is trying to make to give UVM a huge haircut here. And that's the way it is. That's life, okay? Here's what surprises me. That doesn't surprise me. Here's what does surprise me. I can't see that the UVM leadership is really defending themselves. If somebody can call any of this a defense, I mean, I'm just amazed because the UVM network now, the Academic Medical Center is actually at risk for survival. I know really important people that know this thing backwards and frontwards, who think that the UVMMC is going to have to sell the Academic Medical Center to somebody who will play a different game. Thank you.
Thank you for your comment, Mr. Davis. I have an email address. H.L. Bauman, VT. Hey, how are you?
Hey, I'm well. My name is Heather Bauman. Thank you for this opportunity to speak to the Green Mountain Care Board. Like Betsy and Becky, I am a member of UVMMC's newest union and the Support Staff United. I'm a phlebotomist here at the hospital. Our union formed back in January of this year, and we've been in negotiations with the administration since May. You've heard from Becky and Betsy, and you've no doubt seen the 118 comments submitted by staff from UVMMC. They came from members of our bargaining unit. And as you read through them, as you listened to my colleagues, I'm sure you got the gist of it. As a group, we are not being paid livable wages. We struggle every month to make rent and to afford groceries. And we cannot access the wonderful care offered here at the hospital because the insurance offered by the medical center, our contribution is too high for many of us to afford. So most Wednesdays for the past couple months, before and after our regular shifts, sometimes instead of spending time with our families or getting rest, hundreds of us gather in person and on Zoom at the bargaining table to do the work of bettering these conditions, our working conditions. We're proposing changes that would bring up our wages and make healthcare more affordable for the thousands of Vermonters who are a member of our bargaining unit. And I really appreciate that Dr. Leffler said that we need to pay our people well. We appreciate that, and we look forward to being paid well. But so far, the administration has been unwilling to support our efforts to make sure that the support staff is earning a livable wage and has access to affordable health care. We understand that traditionally the board doesn't get into the weeds on how specifically the medical center spends its money, but we implore you, please, please take a very close look. We are asking you to help ensure that the state's largest medical center, the region's level 1 trauma center, and the largest private employer in the state does not balance its budget on the backs of its most marginalized and lowest paid staff. There are more than 2,000 people in the support staff union, and we are the backbone of the University of Vermont Medical Center. For far too long, we have been an afterthought. I'm here today representing our union and who you've heard from in the submitted comments and who you've heard from earlier speaking. I chose to speak up. We choose to speak up because we are no longer willing to accept being an afterthought. It's time that the people who power UVMMC are a priority. We are the hospital's most valuable resource, and the budget should reflect that. And again, I appreciate that Dr. Epen stated a commitment to providing care to everyone who walks through the door. And I just really wish that that included the employee entrance. So thank you for your time.
Thank you for your public comment. I see no more hands raised. We'll take just a quick 2-minute break. And Dr. Epen, do you have closing remarks you'd like to make today?
We have each of the hospital presidents who are going to make the closing remarks today.
Okay, all right. We'll take a quick little 2-minute break and then we'll do that and shift gears. Thank you.
Do we have a little bit longer, Chair Foster? I just need to call in and I could use a comfort break. I'm sorry. Is 5 okay?
Of course. Yeah, no, of course, Cassidy. How about 8 minutes? We'll go to 3:40. Is that enough time for you?
Thank you. You're so kind.
Right.
Thank you for your consideration. Thank
Yeah,
you.
yeah. Thanks. All right, 3:40. Thanks.
Okay, great. Sorry for that confusion. We had the wrong slide up. We are still in regular session. We are not going to executive session. And Cassidy, I'm just going to send you an email, or I can just say this before we get started. How are you doing? This will likely go a bit longer.
Yes,
you
I'm here as
okay?
long as you need me. I'm here for
Okay.
you. You just let me know what you
Okay.
need and I'll be here,
Okay,
of
and
course.
just give us a heads up when you do need those breaks.
Thank you. Thank you.
Thank you.
Cassidy, are you all set?
All set. Thank you for your consideration.
No, yeah, of course. We have 3 board members. Let's see, Robin. And Dave. Great. Okay. We will resume. Dr. Eapen, I'll turn it to you for any closing remarks the UVM folks may have.
I think we're gonna go back to the hospital presidents and have them have the closing remarks. So we're gonna start with Steve, I believe. Thanks, Steve.
Thank you, Chair Foster, Green Mountain Care Board, and all the public comments today. This is a critically important discussion for the state of Vermont, and I appreciate all the dialogue today, everyone trying to do their best to get it right. As Vermont's level 1 trauma center, cancer center, children's hospital, and academic medical center, the medical center plays a crucial role in the health of our community, both locally and across the state of Vermont. We take that role seriously and we're very proud of it. In recent years, building a budget that allows us to deliver on that mission has become increasingly difficult. We've tried to navigate a very difficult economy, an extremely tight labor market. Our 24 budget would result in a margin of 3%. Money that would be used to reinvest in our future, in our staff, equipment, and facilities, and most importantly, to better serve the patients who need us. Last year in 2022, we lost nearly $23 million. That is unsustainable. Through tremendous hard work by the 8,000 employees at the medical center in 23, we're going to meet our margin target. That's a first step in regaining financial strength so we can be strong going forward to meet the needs of our patients. We're working very hard at the medical center to do our part in reducing labor expenses where possible, growing our own workforce, and making changes to improve patient access and revenue at the same time. Complicated, difficult, but important work. At the end of all this, our budget discussions with you come back to a simple reality. As a nonprofit hospital, we cannot be prepared for the next pandemic, support our aging population, and address challenges to access without budgets that allow us to cover the expenses of providing essential healthcare services to all Vermonters who need us. The budget we submitted reflects what we believe we need to meet the care needs of the population that we serve. On behalf of the 8,000 employees at the UVM Medical Center, I look forward to continuing our conversation with you about how we can ensure a healthy future for all Vermonters. Thank you.
And Owen, just to be clear, this was me, Chair Foster, I apologize, but I forgot this was only University of Vermont Medical Centers. And so each of the presidents from the other partner organizations will have their closings after their sessions. So that's all we have for today for this until we go into executive session.
Great. Our logistics will need to adjust a little. Director Lindberg, are you here? It's a lot of
I'm here.
boxes. Yeah, there
Yep.
you are. Okay. Do you want to go straight to Porter now? Or
Yep.
yeah. Okay.
Yep.
Great.
All right. Let me just share. All right, so we'll have some themes. I think we've covered quite a bit of some of the material in our conversations already, but there are a few things unique to Porter that I'd like to cover. So one is, of all hospitals, Porter showed, the highest growth in NPR and the highest growth in operating expenses. It seems like the two things that are driving that are a favorable cost report, and it looks like there's some significant increases in outpatient services at Porter. So do I have that right?
That, and there is a little bit of a unique piece to Porter, Sarah, in terms of when we broke down the increase in NPR for that 2-year period. We had 3 different buckets. We had the volume component, we had the rate increases from Medicare, Medicaid, and commercial. And then we had this other category that represented payer mix, bad debt, and charity shifts from 22 to 24. And for Porter, there was a significant amount of bad debt, meaning we wrote off a significant amount of claims from our Epic transition. So when you look at that bad debt level back in 2022 compared to the 2024, it actually looks like a revenue increase just because there's less write-off of revenue. So I would just highlight that one kind of uniqueness related to Porter.
Okay, that's helpful. And we see Porter, one of the very few hospitals where that NPR line is above the operating expense line. So I'm seeing some, pretty strong financial recovery at Porter. Do you know why the cost report was so favorable for Porter last year, or any guesses about that?
So since they're a critical access hospital, Porter gets rate inflation, if you will, on their Medicare patients. So when you think about the high use of contract labor and the salary adjustments that we've needed to make, that then worked into the cost report settlement, because that's how we get the rates for the critical access hospitals. So that's really what drove that increase there and related to the cost report.
Okay. And would you highlight anything unique about the employment cost per FTE at Porter versus what we already have discussed?
Okay. I don't think there's anything unique there, no.
Okay. And then this one, I think, I'm sorry, I keep looking at the wrong screen when I'm trying to drive. So we do see this, large increase in utilization. Again, that's just an adjusted discharge. And if I'm reading the numbers right, it seems like a lot of that is driven by shifting and seeing more outpatient care revenue. And so that adjusted discharge gets pulled way up. And I did notice in one of your responses that I'm just curious if any of that change to revenue is being driven by the sharing of orthopedic services at Porter.
But I'll let Scott, I think Scott's back online, Scott Como, the CFO of the Board Medical Center. I think he can validate that, but I do think that that's correct.
I can
Sarah.
comment on it. I can comment on it, Rick, if Scott is not online.
Okay. Go
I'm
ahead,
here.
Tom.
And you're correct, Rick. There's orthopedic activity involved there. Part of the outpatient utilization drivers also are radiology and lab.
Absolutely.
But you've got it, Sarah.
Okay. All right. And then for migration, it was actually, I had never really looked at it this way, so I was surprised to see how much care is being imported or in migrating to the Porter service area. And then the only thing that stood out here that I wanted to make sure I touched on was I was a little bit surprised to see such a substantial bump in the Medicare expenditures in calendar year 21, and didn't know if you had noticed that on your balance sheet, or you know, if you could have any insight about what was driving that kind of spike. I know you only saw half of those funds in the HSA, not necessarily at Porter, but just curious if you had a bump in Medicare utilization that was notable.
Nothing is coming to mind right now. Certainly on the revenue side, again, going back to the impact of the contract labor that would show up, but in terms of utilization, I can't think of anything specifically that would have drove up a higher proportion of Medicare there, unless Scott and Tom have any thoughts.
I have noticed the trend as well. I can't put my finger on exactly the driver though.
You know, if I had, again, without good afternoon, folks. This is Tom Thompson, the president, COO of Porter. Appreciate your work. First time I get to chime in today. If I had surmised at this, I'd also say there might be a little shift of commercial patients from our market. So that might also contribute a little bit to that data point.
Okay. Yeah, and the only other thing that came to mind is I think that is when the cyber attack might have affected some of the ability for services to be provided at the medical center. I just didn't know if that also might be contributing to that spike.
That could have contributed for sure.
We did a lot of diagnostics at that point from the medical center's patients, yes.
Okay, thank you. And then as far as the cost report goes, among the peer group, Porter stands out as quite large for a critical access hospital in this peer group. Again, I think that's likely picking up some of that shift to the outpatient revenue. And then we see quite a relatively low acuity of 1.2. Talked quite a bit about your initiatives related to CMI. Anything additional you want to highlight specific to Porter?
No, nothing there.
Okay. And do I have it right that increasing the CMI for Medicare would not necessarily affect reimbursement there, since it's the cost report?
Correct. Yeah, CMI. Yeah, correct. CMI increases for critical access hospitals really don't have a material impact.
But if the severity is increasing, other payers might, even if it's the same rate, they don't get a rate increase. If the coding shows a higher severity, they still might, the reimbursement might go up commensurate with the services that were provided.
For other payers, there will be a small impact, but again, most of the CMI impacts are with Medicare patients. Yeah.
Okay. And then we see, as you were alluding to, that the ratio of admin to clinical salaries quite low here, probably due to the fact that a lot of those are flowing through UVMMC's cost report. Anything to flesh that out?
That's the connection that that can be made there in terms of the shared service FTEs and costs that are brought to bear across the network are quite small at the Porter Medical Center.
And for cash available for operations, we see you right at the median. I was just curious, you talked a lot about how you really consider yourself a network, and I just didn't know if you had specific benchmarks for the amount of cash on hand or margins that is at each hospital level, or if you really monitor more that of that network wide.
So the margins, we do establish targets for all the partners. Cash, we view that as we monitor that from a network perspective. Each partner still does have individual days cash on hand balances, as you can see here in the data, but that isn't. We don't have specific targets for days cash on hand for the individual partners. That we target as a network in totality.
Okay, and are you mostly looking at the EBITDA operating margin for those hospital level targets?
Exactly.
Okay, great. Thank you. And then, yeah, profitability, I think is another place where you're very close to the median. That's right. You're actually exactly at the median, which is why I can't get you to pop up on there. And then we do see that the cost per adjusted discharge is just above the median at 12,000. So despite a potentially deflated CMI, that is already within the range. As far as cost coverage goes, so I think, again, this might be some of that care pattern goofiness that maybe led to different services. Often see bigger dips when we have smaller numbers. So I don't think, I think that's why that looks as dramatic as it does. And I know that, among critical access hospitals for commercial, that Porter is showing, combined the lowest cost coverage at 130% of the Medicare allowable cost, and, among the lower for Medicaid. We see that, the cost coverage on inpatient is actually below the Medicare allowable cost at Porter. And for outpatient, it is, have 150 in my head, and so there it is. So again, seeing that value being the lowest among the critical access hospitals. And then finally for RAND, this is back 2018 to 2020, but we see very near the median back then for that time period for inpatient care, and a bit below the median on the outpatient side. And so again, this is taking all those commercial payments, dividing by a standardized unit of service to try to get a sense of how much things cost on a unit basis. So yeah, so that was kind of the material that I thought was important to highlight for Porter specifically. So Chair Foster, happy to turn it back to you for board questions.
Great. We can just go, I guess, in the same order if that's helpful. I don't know if Ms. Member Lund, you have any questions, but go ahead if you do.
Sure, thanks. So I just want to confirm that Porter intends to participate in all the ACO programs with OneCare for 2024.
That is correct.
Thank you. Could you speak to how you are integrating e-consults into the hospital at Porter?
Absolutely.
Yes, so our e-consults are a network-wide initiative. So it's really open to all hospitals across the network.
But I was curious about what specifically was happening at Porter.
In terms of what? I'm not sure I'm following.
So how has Porter's providers been using the e-consult feature? Are they using it more or less than other network hospitals? How is that rollout going? And I'm just looking for a little more detail about Porter. I'll just note that I would say that your narrative was somewhat light for Porter in terms of detail on what's actually going on with this hospital.
Got it. Thank you, Robin. So the way we rolled out e-consults was in a staged fashion. So we did start with UVM Medical Center. So if we look at the total volume of e-consults, UVM Medical Center is higher for that reason. And then in this fiscal year, we've rolled it out to the rest of the network hospitals. And while the volumes are smaller at the other hospitals, they're mostly proportional to the size of the hospitals.
Okay. So on page 30 of the narrative where you've outlined the traveler's costs. I'm wondering if you could speak to why the dollar amount for travelers is greater at Porter than at the other two network hospitals. I had thought I had read something in the narrative that you were centrally procuring. So could you speak to that, please?
Yeah, we have centralized that process, but it does take time for that centralized rate card to look the same across the whole network. So so contracts are renewed on typically a 13-week period. And so if we have a consistent rate card as a network, it'll take time before those contract renewals actually are impacted by that rate card. So for Porter, it means that they haven't had enough contracts come up for renewal where they start to get down closer to the 105 that we have for the other organizations, but they will eventually get there.
Thanks. Turning to the PHSO, I was noticing in your responses submitted this week, I'm just going to pull those up on my other screen. You included, and I appreciate it, 2 tables outlining the FTEs assigned to each by hospital. So this is page 3 and 4, tables 1 and 2. And I noticed that you included that for Porter, there are additionally about an FTE of support for the community health team that's not part of the PHSO. Could you speak to that? And is that a Porter employee, someone else in the HSA?
So are you referring to the table 2 at the bottom?
Yes.
Yep. So those are not network non-PHSO employees. So those are when we speak specifically about the work that the PHSO has done to streamline blueprint funding. These are funds that are outside the system. So we just wanted to make sure we delineated that to make sure that it was clear.
Thank you. That's helpful. So could you just explain that a little bit, though? Because I thought as the fiscal intermediary that all of the CHT funds flow through the hospital.
So they may flow through, but they would flow to an organization that uses those funds to fund their own FTEs.
Okay, I understand. Thank you. That's helpful clarification. And then in the narrative, also in response to these questions, when I asked about the PMPM Blueprint and OneCare payments and how those flow through to primary care, the answer was that those flow directly to the practice. Could you speak to how that works at Porter? How does that practice experience that funds flow? Like, did they see it directly? How is it included in their practice level budget?
So I can speak to it at a high level, and then someone who has more specificity may want to add. But so from a high level perspective, all of those funds flow directly back to the practices, whether it's Porter or any other practice. So they're not coming through the PHSO. They're not coming through a central intermediary. They flow directly back to the practices. So how each individual practice then uses them are not under the purview of population health. Does that answer your question?
And I can go a little bit further, Robin, too, in terms of the actual allocation of the PMPM. Internally, we do it the same way as the money. In terms of how the money comes into us, it's based on attribution. So internally, we do the same thing. We allocate the dollars when they come into the health network. They go back out to the primary care practices and shows up as a revenue item for them based on their attribution.
Great. And I was hoping that someone from Porter could answer this next question, which is for your FTEs that are assigned to your PHSO, can you speak to how those folks get connected with local resources and understand the local environment if they're not physically located in your area?
They are physically located in our areas. They're attached to our practices from the PHSO.
Okay, thanks. And then I just have a couple more. So I noticed in your narrative that you are, and I think actually you talked about this last year, that you've started to replicate CVMC's workforce programs at Porter. I wonder if we could get an update on how that's going and where things stand.
Yes, I can start. I'd be glad to start. This is Tom. So slow but sure. I mean, we've been most invested in a partnership with Hannaford Career Center in Middlebury with an LNA training program that where we provide funding for folks that we interview and hire to work both in the hospital and at Helen Porter, our skilled nursing facility. They work at a level while they go to school and train, and we support that training too. So that's been our most successful effort right now at grooming our own LNAs. We've been recently working more and more. Well, we also worked with the Vermont State College system to then fund those folks, some folks transitioning to LPN programs. And that's the next step we took with that. And that's at a smaller scale, but growing. And we expect to expand significantly in the coming year with the overall workforce initiative of the network. So by LPN, so we'll get to the full point where CVMC started years ago with LPN, or excuse me, LNA to LPN to RN and then beyond.
Great, thank you. Hold on just one moment. I just need to switch to another list here. Switching gears a little bit now, I wonder if you could let us give us a better understanding of what's going on with Helen Porter Nursing Home. What were the fiscal year 22 losses? What in fiscal year 22, and what are the projected losses in fiscal year 23?
I'll let Scott answer that.
I don't have the FY22 number handy, but I know that in the current year, we're projecting a $5 to $6 million loss.
Okay. And do you have a sense of are there, I guess the way to ask this question is, are there ways that you could potentially improve the profitability of Helen Porter? And have you looked at independent nursing homes that turn a profit to see if there are things you can learn from them?
Well, so this is Tom. So I'm a little confused because this is a little bit out of the, I appreciate that this comes under our global financial statement, but it's non-hospital entity. I will tell you what we've done. We've worked extensively on all elements of the revenue stream at Helen Porter and the whole financial statement from the revenue side and the expense side to optimize operations. We're also engaged in that effort as a network right now to lever our collective resources to optimize financial performance, including the government payers. A challenge for Helen Porter is that we have maintained full capacity the entire time through the pandemic beyond, and largely with agency staffing. So we have at any time 30 to 40, or approximately 30 agency staff in a skilled nursing facility where we're receiving 70% Medicaid payment. So, I mean, a lot of that loss has to do with the fact that we've chosen to maintain our same capacity with very high level labor costs. So, we are looking to optimize every lever on financial status for Helen Porter. We also are working on a network-wide initiative to quantify the value add for our acute care settings of how we accept patients into the skilled nursing setting to lower the total cost of care, which is why our spectrum of care at Porter is so valuable. So we're working on that avenue also.
A couple other things maybe I would add is that we did apply, both Helen Porter and Woodridge did apply for increased Medicaid rates to to help with the significant cost inflation that they too have experienced. CVMC actually did get their rate request approved. We anticipate Helen Porter, should be any day now, which will help improve the finances. And as Tom said, we're actually in the process of looking to manage our post-acute facilities as a single service line, if you will, looking to optimize them from a leadership perspective, operations, revenue capture. We've submitted an RFP looking for a partner to partner with our leadership team to look for those opportunities across all of our post-acute facilities.
Thank you. And the reason why I'm asking about it is because the losses at the nursing home do have an impact on your bottom line, right?
When we roll everything up as a network, yes, the nursing homes that we do own impact our overall network bottom line.
Okay, and it used to be that it would impact Porter's bottom line. Is that no longer how you're doing it financially?
We still look at Porter Medical Center. We combine the two, but that's just historical. In reality, we're looking at the overall network margin when we're looking at those post-acute facilities, because we have some in New York State as well.
Okay. In looking at your profit and loss, it looked like, and you've spoken a little bit about Sarah mentioned the increase in outpatient revenue and decrease in projected inpatient. Is that shift related to just general service line changes? Could you speak a little bit more to that as to what is causing the shift of inpatient to outpatient? Is that the ortho and the radiology that folks just mentioned?
Yeah, that's the majority of it. I don't know if there's any other services that are shifting to outpatient, Tom and Scott.
Outpatient lab is also contributing heavily to that.
Okay, thank you. And then lastly, under your operating expenses, it looked like there was a 30% increase in other operating expense between fiscal year budget and fiscal year 23 budget and fiscal year 24. Could you just explain what that's related to?
Other expenses.
This in the narrative, Robin? Yeah, I'm not sure what you're looking at, Robin. Is this in the narrative?
It's in the, I think it's in the P&L. I don't have it in front of me, I'm afraid, but
yeah, no, it's okay. We'll get back to you with what drove that increase.
Sure, of course. And then I guess I did have one other question that I found. So in relationship to the increase from the favorable Medicare cost report, how is that reflected in your commercial rate increase ask for Porter?
If you look at our narrative, so we do have a grid like we've done for all the other hospitals for the rate increase. I'm just flipping to it now. So we do the calculation the same way that we do for UVM Medical Center and for CVMC. So you see it right there in terms of the Medicare rate increase that we're anticipating. The 640,000 is what we're anticipating there in terms of a rate increase. We also have the Medicare ACO rate increase, which is really a shared savings estimate at this point. But the same math that's done for our other two hospitals is done for Porter, and that's really what drives the rate for our critical access hospital to be lower than it is at our other two hospitals.
Thanks. And then I guess the only other question I have is when looking at Porter's operating expense increases compared to other critical access hospitals, it seems quite high. And so I'm wondering if you could just kind of talk me through that. Because quite frankly, when Porter joined the network, part of, I think, what folks were saying and I think hoping was that being part of the larger organization would achieve economies of scale and would help with expense growth, cost containment. So, but seeing those numbers compared to other critical accesses now, that doesn't seem to be the case, at least this year. So if you could just respond to that, I'd appreciate your thoughts.
I think a component of that just this year, it could be our shared service allocation that changed for Porter, which would be different than other critical access hospitals that that are not part of a network. Certainly, when you look at the core expenses and the financial performance of Porter, cash balance, they've certainly the performance has increased since they joined the network, but in terms of that expense, that may be what's behind that number. But we'll definitely, as I said, look into that expense number and get back to you. Looks like Tom wants to make a comment as well.
Yeah, I will add that we have also made in prior years, Porter had, quite honestly, artificially limited some expenditures that needed to be made. And I'd say that laid largely with staffing investment. So as an organization, we have made a commitment to staffing investment, both in terms of people and in terms of pay. In the union environment specifically, just to mark one, we have one union, it's the Registered Nursing Union, and we've provided for contracts that were in excess of 30% in the last 3-year period of time, and are similarly working. Looking at the other speakers who have talked today in the public comment, we've also, similar to our other partner organizations, been focusing on bringing all of our employees up to a market rate. In Porter's case, we had a longer way to go on that than our other partner organizations, and making up for lost time in that area. So that has been a key area of focus for us as an employer and an organization.
Thank you. Those are my questions.
Just a couple kind of similar along the last one that Member Lunge asked. For the administrative costs, you had a correction for the shared services that were all going to UVM Medical Center. Is there a correction that can be done for the apportionment that should be going to Porter?
Absolutely. Yep.
Have you done that?
We didn't do it for the response that we sent back, but we can send that and follow up.
Yeah, okay. If you could do that for Porter and CVMC, just so that you're not normalizing for one and the others are artificially low, that'd be good. I don't know if you know this, but I was born at Porter. My brothers were born at Porter, and my family goes to Porter a lot. A nice hospital. But one of the things that was sort of in the town back in the day when you're affiliating with UVM was people were really concerned that it would become more expensive. Is there a way to look at or compare whether or not Porter's expenses have grown faster as compared to peers since the affiliation?
If we have access to the critical access hospital data there, we might be able to do that type of comparison, but not something we have today.
Yeah, I was reading, some of these old Digger articles, and one of them, let's see if I can get the date on this one. I'll just read you the quote from the former CEO, quote, "Any new affiliations must bring greater value to people in the community and the network and will be scrutinized through that lens. Expansion will not hurt consumers. What consumers can expect is that we will always have the affordability of healthcare at the forefront of all of our strategies. We clearly get that affordability potentially can be a barrier to access to care." And that concept of the affiliations not harming consumers. I was wondering how we as a state should look at that and evaluate whether or not this affiliation between UVM and Porter is driving up some of these costs, or if it's saving them, to Member Lunge's question.
Yeah, like I said, we can take a look at that. Just not something that we're prepared to do today.
So to the
I think in the future, Owen, I think what we need to do better is be able to come back to you and say, here's the value that Porter is getting as a result of the affiliation. Here are the clinical exchanges that are going on. Here's how the patients are benefiting. It wasn't the way that we prepared for today that I can recall, but I hear that that's important, and you're bringing back these quotes in the past that I think have cited that, and I think we believe that we're doing that, but let's bring that back to you. And if there's a way to do it quickly, I'll do it quickly, but it isn't something that we've prepared, I think, for these budgets.
Yeah, and Chair Foster, I had this in my closing comments, but I think one of the biggest advantages is the access to resources that none of us could possibly have on our own. I mean, that's in my career, a pretty long career in health systems, that's always been the advantage a small organization received. But I'd also say it's been the ability to really help us with a high value strategy as an organization. So at Porter, it's given us more access to clinically appropriate services and access to clinically appropriate services scale to our organization. The ability to bring those in a financially sustainable way and capitalize them. We have done a ton of it yet because capital's been very light because of where we're at. But I think it's been the ability for us to help get a lot of strength behind a high value strategy at a local community level.
Yeah, that'd be great. It might not be something we prepared or discussed prior to this hearing, but from the policy perspective of what we do, we hear people criticize and say, hey, these affiliations and this consolidation is driving price and it's driving costs. And I just would love to have a fair, honest conversation, pro and con, on that, because I think it is something policymakers think about quite a bit. And if there's increased costs that are coming from the affiliation, we should see if there's a way to remove them. And if there's increased savings that are really materializing to assist in this affordability challenge, we should definitely be highlighting them and recognizing them and informing
increased
ourselves.
Access and increased quality, right?
Yeah. My brother was complaining that they don't have all these services that they want at Porter. And I said, well, do you want to pay more for insurance? Because that's what it's going to take. And that leads me to my next question, which is, you guys all know we're doing Act 167 work. It's underway in earnest. And one of the things that's happening is, are there infrastructure overhead or service lines that can be safely limited or removed? And I guess my question is, if there's a recommendation from the consultant on that says that that's a cost-saving opportunity for Porter, is Porter and UVM going to be open-minded to that kind of recommendation?
Absolutely.
Yes.
Great. I don't have anything else, but it's nice to see you, Mr. Thompson, and thanks for letting me ask you all questions on this.
Thank you, sir. Good seeing you.
Thank you.
Hi, I just have a few questions. Sarah, is there a way you could put up Exhibit 9?
Yep, it'll just take a minute.
Thanks. I think my general comment too is similar to Member Lunge. It was a little light on the submission compared to most of the other hospitals. We're getting a lot of its network, but trying to find Porter specific stuff in there is a little light, but I think largely adequate. It's just hard to pull it out the way we organize our information. So I'm a little confused by a few of the components of this exhibit, which is in the net patient service revenue FPP lower box. The all other, which you explained for FY24 in the letter, that made up of employee self-insurance plans, small non-commercial, non-contracted commercial, public agency, workers' comp, self-pay, other. It's on Exhibit 9, it's a really big number in 21. Then 22, it's about half. Then 23 is what you provided us, the breakdown. But then the commercial, so is that similar for 21? Is that a similar makeup of those elements to the all other category there?
We're going to have to go back and take a look at that because we do make movements from time to time in terms of where insurance lines roll up in these roll-up categories. Just looking at this list here, nothing comes to mind in terms of what would have been a significant change there, but we can definitely give you that same breakdown for 21 that we've given you here for the 24 budget.
So part of why I asked that question, oh, go ahead.
I was just gonna I had forgotten to ask that I was surprised to see the self-pay revenue equal at CVMC and Porter, and just curious if that's typical to have such a high proportion of self-pay at Porter.
Yeah, that's so self-pay is a combination of two things. So one is those that are covered by insurance and they have their co-pays, and those that are truly uninsured. So the fact that those two are near each other means that the commercial amount of business at both organizations has to be fairly similar, because there's not a lot of self-pay in Medicare and Medicaid.
Okay, thank you. Thank you, Board Member Merman.
Yeah, thanks. If you go back to that exhibit though, the reason why I ask is initially when I was looking through the various hospital submissions, I noticed there was 100% increase in commercial revenue from 21 to 24 at Porter, which seemed striking to me. I was trying to understand that, but if you actually combine the commercial and all other, while it's still a strong increase, it goes from 46 million to 63 million. It's definitely, it's more, I don't know, is that 50 to 50%-ish or something. So do you have any reflections looking at this? Do you think the commercial business at Porter is just skyrocketed from 21 to 24?
No, again, this has to be a mapping change between those time periods, and so we'll get you the change that happened between 21 and 24.
Yeah, there was a billing system conversion going on during that time, and I'm sure that classification, as Rick mentioned, is part of it.
Okay, that'd be really helpful, because I think that would probably change some of the assumptions in the Exhibit 10 as well, which I think would be helpful to clarify. So the other thing I just wanted to point out, I don't know if it's really relevant for this discussion, but I think it's kind of how we're capturing data. I mentioned it to you, Sarah, on the tool. If you could pull up the tool for a second. Under the utilization tab, just being in the ED business and kind of knowing what other departments roughly have for volume, the ED volumes looked pretty high to me, with a remarkably low admission rate. But my understanding, actually talking with Sarah, I think, is you figured out that might be including some of the urgent care patients are slipped into that. Is that what you said?
That's correct. We discovered that there is a revenue code that Porter is using in the hospital discharge data that we're not seeing from other hospitals that looks to be affiliated with urgent care.
Yeah, so I just want to kind of flag that if you were to look through this and say, wow, those ED visit volumes look off for us. We're over counting them in our system, which would make you look like you would have a relatively, I'm sure very few people are getting admitted from urgent care, if any, so your proportional admission rate would look higher. That's just one thing I was noticing on the data. That's all I have for now. Thanks.
Writing that.
If I could follow up on a couple of points that all three of my colleagues have had questions about. And that's where is the savings, or where is the improvement in quality, communication, care coordination, or outcomes following the consolidation? And Chair Foster asked if we could find that data. There are publicly available sources, and I hope we all get a chance to look at those. The Healthcare Cost Institute, the Healthcare Pricing Project from Yale, and the RAND studies on pricing transparency. All of those have looked at what's happened as hospital systems have consolidated. And if we don't like reading studies, we can Google the effects of healthcare consolidation on pricing and quality. What the evidence shows, unexpectedly, we expected better care coordination, better quality, better communication, and lower prices when this trend started 20 years ago. But we've not seen those things. It's been disappointing from a policy perspective. Across the country, and these data sets include Vermont, but across the country, consolidation has not improved quality, access, affordability, communication, outcomes. It's raised prices. And the revenue that's come from the prices shows up in infrastructure projects, administrative layers, growth in those layers, and higher executive compensation. When I joined the board a year and a half ago, I wanted to find where those things, whether those things were happening in Vermont or not. They appear to be happening in Vermont. So if you have data from within that shows savings after consolidation, savings from the shared service organizations, improved access at organizations after consolidation, we would like to see them, because they're not available in public data sources. That you're telling us that things are better, but we're not seeing that in the data that you provide us. And that is contrary to what the rest of the country is reporting.
Member Walsh, do you have anything else? Okay, great. I'll turn to the healthcare advocate.
Thank you, Mr. Chair. Mike Fisher here. Just because nobody else is focused on it, let me just spend a moment looking at the numbers, make sure I'm right here. I think on Porter's profit and loss statement, you're showing projected 14 million excess revenue.
For fiscal year 23,
yeah.
Mike.
Yeah. And quite a large NPR, 28.4 increase. So there's a lot of utilization increase. Am I reading that right?
Utilization increase, but also a fairly significant increase in Medicare revenue from updated cost report settlements. So catching up on the fact that 21, 22 saw significant increases in contract labor and other expense growth, that you're now seeing the adjustment for that cost report settlement in those numbers as well.
And that boils down to, I mean, your request is a 6.86 commercial rate increase. Is that also right?
So that the 6.8 commercial rate increase is impacted by the Medicare rate increase that we think we will get in 24. The cost report settlement that you're seeing in the 23 data is specific to 23.
Okay. Thank you.
Public comment? Okay, and I'll turn it back to you, Mr. Thompson, for any closing remarks you may have. Oh, I'm sorry, we do have a public comment. Mary, how are you?
Hi, I'm thinking I'm having some internet issues because you guys are moving a little slow, so I hope that you can hear what I'm saying. I'm a nurse at Porter Medical Center. I work on the birthing center. I've been there 27 years. So I've been here before affiliation and plan to be there for a few more years for sure. I'm also the treasurer of the Porter Federation of Nurses and Healthcare Professionals, which is our nurses union. And just a note that we are in negotiations for our 4th contract as we speak. We have some sessions coming up in September. We had some questions regarding a comment, a narrative on page 20. It listed 3.9 labor expense inflation factor for PMC. This is considerably lower than the labor expense inflation factors projected for UVMC and CVMC, and lower than the 5.2 Bureau of Labor Statistics projects for 24. And you're asking for the 28% increase, and we just want to find out what accounts for that wide discrepancy on that. I can continue on with my questions, or you can answer, but I'm not sure how you would like to address that. I just have a few questions.
Yeah, I don't have a problem if you have questions, if that's okay with the Porter folks.
Yeah. Oh, okay. I'll just continue. Maybe I can get a written response on some of these questions. And what with the budget that they've that you've presented for PNC, what is the total amount of percentage that will go to management? And what will go to traveler salaries? Another question we had as a union group. And actually, a bunch of you have already spoken or asked this question regarding the benefits of our affiliation and the cost savings and the cons of that affiliation. We too would like to know that information. One thing that might be unique to our hospital is our administration has a dyad system for how they're running the upper management. And we wanted to know if you had any information on the effectiveness of this dyad structure and the cost savings on that or expenditures on that. And I think everybody else kind of talked about the other things, like I said, for the affiliation, the savings and the pros and cons of that. Thank you very much.
Great, thanks for your questions. Mr. Vince, if you'd like, you can just send that into the board and we'll post it with your materials, because I think they're relevant to the budget decision, some of the questions. So we can do that. I don't see any others, so I'll turn it back to you, Mr. Thompson, for any closing remarks you may have on the Porter budget.
All right, Chair Foster, thank you for that. Thank you, Mary, for hanging in there and getting your questions out there. It's good hearing from you. So during this long day, I looked at my originally planned remarks and wanted to go on and change them all, right? So because it's been a very informative day and there's been a lot of discussion. I'll try though to stick with where I originally was going to start, because I think things still hold very true for us. So in preparing these remarks, I looked at the Green Mountain Care Board's mission, which is a focus around accessibility, affordability, and quality, and saw that as being extremely aligned with Porter's strategic plan. In our organization, we have a nice componentry of the spectrum of care, of ambulatory care, acute care, skilled nursing care. We also have a strong focus on collaboration with agencies of similar mission in our community. So we know very much that we're not in this, we aren't the end all be all of everything in our community. And so actively seek out, we actually refer to it as intentional collaborations, partners that help us fulfill our mission. So that permeates everything we do. This is the fourth Green Mountain Care Board hearing that I've been privileged to serve as president of Porter. And each year in my history and even preceding my history, we've always been pretty well complimented by the board for the responsibility of our budgets. And this year is no different. The thing I'd like to add though is I've been a CEO for 35 years. And this organization, the UVM Health Network, puts more rigor into the budget prep process than any organization I've ever been privileged to serve in. So we are very focused on being well benchmarked and providing the data that we believe will help you serve your role as regulators. I will also add, though, it is really critical, that this budgets for our organization and our network be approved as presented to really help bring to life that stabilize and sustain focus that we both agree is really important for the healthcare system in Vermont. At Porter, like all of our partner organizations across the state, we've had a lot of profound challenges. The patient demand has been really challenging to manage effectively, and that's one of the best benefits of our health network is the ability for us to move patient care across our different settings as effectively as we can with the resources available to us. We also have talked a lot about the workforce shortage. I think the thing I want to point out here is the fact that Porter has always maintained capacity in all its care settings, despite the high cost of agency staffing, which we've been blessed by, but also it's been a huge expense for us. As I look at the 24 budget, we need a budget that we have submitted to help us address these realities that we're facing so that we can help us recruit, hire, retain, key professionals and support staff throughout our organization, to help us continue to invest in the pipeline programming and expand upon growing our own staffing, which is a huge part of our future, and to address some of the new areas that we've not gone into before, but need to, things like housing in our community to help support the recruitment and retention of staff. The budget we've submitted also will, combined with the philanthropy efforts that we're really focused on in our community, help us maintain the level of resources in our balance sheet to bring needed investment to aging facilities. Right now, our Helen Porter rehabilitation and nursing is one of those areas of focus. We're basically rehabbing a 30-year-old facility to serve some of our community's most vulnerable adults, as well as the mission it serves to help take some of that capacity out of our acute care settings and lower total cost of care. The next thing on that horizon, Chair Foster, our organization, that a big priority on our hospital campus is our emergency department. And that is the next area of focus in our master facility plan to help replace that facility. We believe we've put forth a very responsible budget along with our organizations. We believe it's very important investment in our ability to provide exceptional care for our community. And we look forward to fulfilling any unanswered questions you might have about that budget. So thank you for your time today.
Thank you, Mr. Thompson, and to the Porter team. We'll take a break for CVMs before the CVMC. Cassidy, how long would you like?
Oh, just 2 minutes is fine.
All right. Well, I need more than that. So let's go with 9 minutes. We'll come back at 4:50 and do CVMC, and then yeah. So see you at 4:50. Thanks.
Thank you.
Thank you. All right, it looks like we got Cassidy and we're down to 3 board members, and my little thing here says we're down to 70 guests. So I hope the fine folks at CVMC don't take that as a slight. I think it's just a long day. I'll turn it over to Director Lindberg.
Thank you very much. So turning our attention to Central Vermont Medical Center, notably this facility showed the lowest amount of growth among the network hospitals for operating expense. Would you please comment on what's different about the expense profile for CVMC versus particularly UVMHN?
So a big piece of that is obviously tied to the, I think you'll see as well that the revenue growth is lower for CVMC. So the expense growth certainly flows with the amount of volume that we've seen change through that period of time. Up until recently as well, in terms of the proportion of the expense base that was in contract labor for CVMC, it was certainly lower than the UVM Medical Center, and proportionally lower than the Porter Medical Center. So those two things are the major items that drive that for CVMC. And again, I think we've got the CFO Kim Patnode on, and Anna, if they want to add any additional comments.
Well, Rick, I think you covered it.
Okay. Any insight about why some of the efforts to minimize contractual staff has been more successful at CVMC versus some of the other locations?
So I'm happy to speak to that, Rick, if that's okay with you. So I think we've mentioned in the past and even earlier in today's conversation that CVMC has a number of workforce pipeline programs that we launched in 2018, and those have had successful impacts on our need for traveler to cover our patient care needs, both at Woodridge, our nursing home, and in our acute care setting. However, I would say we are still utilizing travelers, as Rick alluded to, but I think that's a big piece of why the costs are less potentially, as those programs have been successful in bringing staff on board in different roles, from LNA to LPN, LPN to RN, and now RN to BSN. And we also are obviously taking advantage of the network programs that exist in the surgical tech arena, respiratory therapy, and the like. Did that answer your question?
Yeah, thank you very much.
Sure.
I also noticed that the distance between the operating expense and revenue growth is the greatest for CVMC as compared to other hospitals. Any insight about why that pattern might be true?
Yeah, we've definitely been struggling, certainly financially at CVMC for a little bit. Revenues have not kept pace with expenses. Part of that is, again, the volume growth has not been as great at CVMC as it has been in the other 2 Vermont hospitals. So the capacity that we have in certain services, so OB, the operating room, other services, with that capacity at a certain place, the volume really hasn't always been there to fill that gap. And OR volumes have started to pick up in the last few months due to the peri-op team that we have centrally within the network, but there's still some work to do to ensure we've got strong volumes in all of our services at CVMC. I think you're on mute, Sarah.
Thank you. It had to happen. So I was going to say, this clearly shows that the financial struggles appear more acute for CVMC as compared to Porter or UVMMC. I was curious, it does look like a little bit more ambitious margin recovery at CVMC from 23 to 24. So going from that -3 up to the +2. I was just wondering, how you came up with that kind of benchmark for this budget.
So a piece of that certainly is the work that we're doing in terms of volumes to push where we know we have some access opportunities to get more patients in. Anna can probably speak to some of the efforts we have to use some of the capacity at CVMC, particularly in the OR, where we don't necessarily have all the capacity that we need at the UVM Medical Center. So we've started to, we have been all along, but certainly a more concerted effort to try to move some volume to CVMC. So that all factored into why we're anticipating a larger margin in FY24.
In addition to what Rick mentioned, the other areas that we're focused on is in our ancillary support areas. So respiratory interventions, radiologic interventions are examples of that. So we're bringing more volume down to address the access issues that we're experiencing across the network. Where we have the potential, we'll bring those patients here to Central Vermont for those procedures and tests.
And is the volume you're kind of trying to help CVMC pick up, is most of that coming from, Vermont, or is any of the New York stuff coming down that way?
It would pretty much be all just Vermont patients that would be moving towards CVMC in terms of doing those services there.
Okay, thank you. And then it did look that of the 3 facilities, the kind of cost per FTE is the closest to just the cost alone index for CVMC. So just any reflections about why that trajectory looks a little bit different?
Again, a piece of that is the lower utilization as a total proportion of the staff costs of contract labor that has driven that down. Another is, I believe, just the staffing mix in terms of the type of staff that we have at CVMC. Kim and Anna, I don't know if you have any other thoughts.
No, again, Rick, I think you've covered it.
All right, and as you've already noted, not seeing quite the same change in utilization, particularly from 21 to 22, but did notice an even more significant drop in recovery during the pandemic there. Anything that you want to note about CVMC during that difficult time?
Yeah, again, the volumes definitely are not as robust at CVMC. Even before the pre-pandemic period, which you see there before the 2019, not the same level of growth that we've seen in our other Vermont partners, but we're working towards using the capacity that we do have there at CVMC to meet the access challenges that we have.
Just to add to Rick's comment, I think that's part of the power of the network, is to work in that way as a collective to make sure we're meeting the needs of our patients across the network and across the state by opening up availability here at CVMC. We have the capacity, so having patients come down here is an advantage for them and obviously supports us as well.
Thank you. So as far as migration, not seeing a ton of in-migration. Sounds like that might start to change as you're able to kind of redirect some care. And also seeing this common drop from calendar year 21 to 22. When I see that, I immediately am thinking about Medicare Advantage, and I just wondered if that patient population is you're feeling that more acutely at Central Vermont than some of your other facilities.
Not that I'm aware of that we've seen a higher penetration of MA plans there. But if anybody else has any thoughts there, I don't know, Kelly, if you've seen any data that says that CVMC would be unique in terms of the penetration, but I haven't seen anything.
I'm not aware, Rick.
Okay. And then, this one's probably the weirdest comparator group in Vermont, since we only have 2 hospitals that fit in this categorization, but we do see Central Vermont being below the median in this comparator group in terms of size. And then I think we already talked about kind of getting this adjusted, but we do see that, despite that is at that upper 75th percentile for the admin to clinical salary. So it'll be good to kind of get that adjustment for all the facilities. CMI, anything to add about Central Vermont specifically?
No, nothing more than what we've already shared earlier.
Yeah, and then this one was notable to see. I was surprised to see that this among the peer group was at the 75th percentile when it looked like your cash days cash on hand available were so low. Any idea about what might be different about those data sources?
So this is mid-sized rural hospitals across the country.
Yep.
I mean, what that tells me is obviously there's a lot of mid-sized rural hospitals that are struggling. If at that cash level, the CVMC is at the higher end of the benchmark.
Yeah. Okay. And then profitability actually more favorable than peer groups during this time period might be related to the cash position we just discussed. And then we see that 12,000 per adjusted discharge, which you think might partially be measuring deflated or underreported CMI. As far as cost coverage, this is a place where so we do see some atypical reimbursement rates for inpatient among commercial payers, and a pretty significant decline in that cost coverage in recent years. If we just look at inpatient PPS hospitals, we see that your payment or the typical coverage of the Medicare allowable cost is the second lowest after Northwest. And in the outpatient side, we see that CVMC actually has the lowest cost coverage at 185% of the Medicare allowable cost. So I think just evidence that the reimbursements at CVMC haven't necessarily kept up with some of other hospitals. And finally, RAND is showing the right between the 25th and 50th percentile for inpatient, and just above the median on outpatient through 2020. Anything specific to note about either of those indicators?
No, nothing to add, Sarah.
All right, that's what I had. Over to you, Chair.
Thank you. Ms. Lunge, do you have any questions?
Sure do. So first, again, just wanted to confirm that CVMC will be participating in all 3 ACO programs in 2024.
They will.
Okay, thank you. All right. So on the Blueprint for Health information, I noted in your recent response that in Barrie, the QI facilitators have external responsibility outside of the network. And I wonder if you could just talk a little bit about that and how that came about and why Barrie's different there.
Sure. So we take our community partnerships very seriously, and that bleeds over into this effort as well. So we're supporting our FQHC Plainfield and another practice that's a private holistic practice in our community. So we are providing QI facilitation to those two practices in our community.
Great. And has that historically been the case, Dana?
We've shifted from time to time depending on how engaged they were in those programs, but that's something that we're embracing and very happy to support them in those efforts.
Great. Some of my questions have been answered, so that's good. So on Exhibit 11, for CVMC, I was noting if we look at the travelers line from 21 to 24, in 21, the travelers were quite low, which I seem to recall was related to the workforce pipeline programs, although I could be misremembering. I wonder if you can just speak to that growth and whether you are expecting that your new normal is in the 70-ish range, or whether you're expecting to get back to your lower levels.
So I can start if you want, Anna, then you can
Sure.
you can chime in. So one of the things, so what's unique about CBMC is actually the nurse